Welcome back to News Talk. We turn our attention now to prostate cancer and the treatment options available to men who are diagnosed with this disease. Johns Hopkins University has a reputation for being among the very best places in the country for treatment of prostate cancer. And joining us now, Dr. Arthur Burnett II. He is director of the Male Consultation Clinic at Johns Hopkins. Also with us, Norman Morris, an award-winning journalist and prostate cancer survivor. Their book is called Prostate Cancer Survivors Speak Their Minds: Advice on Options, Treatments, and After Effects. It's good to have both of you here. Thanks very much for your time.
It's good to be here.
This is an important issue. It affects a lot of people and a lot of fathers, grandfathers, uncles, etc. Any diagnosis that involves cancer is a tough one to hear, and clearly this would rank among them. Fair to say?
Absolutely. 1 in 6 men will be diagnosed with prostate cancer. We'll have to confront this. So as you mentioned, we encounter individuals with this disease, and you will too.
And how does it hit?
Well, this is a diagnosis that can be a silent killer. It's not easily...
I mean emotionally, forgive me for
that. Well, emotionally it can impact on individuals because of the impact of any disease, but also the fact that it impacts on various other functional activities of the body, urinary control, sexual function. So therein is a disease state that, to treat properly, could impact a person's sense of well-being. So there's a lot of significance associated with this diagnosis.
Patients, anytime we're talking about cancer, have to engage in a full conversation with their doctor about the options and about the pluses and minuses connected with each. One of the things we hear is that prostate cancer grows so slowly that you might live a long time and die of something else by leaving it alone.
Absolutely.
So is that a real part of the equation when you're talking about this disease?
Well, it's a part of the equation, but when I was first diagnosed, I was working very happily at CBS, doing a lot of work, running around, didn't pay attention to it until I suddenly got prostatitis, which was an inflammation of the prostate. It was a urinary kind of thing, and I went to the doctor because I was running constantly to the bathroom, and it was a lot of pressure. And they did a blood test called the PSA, prostate. What is it called?
Prostate-specific antigen.
Yes, it's hard to say. Anyhow, they did the test, and it was a very low number, which was 1.3, which indicated there was no prostate cancer. Unfortunately, when the doctor was doing a test to test the prostate itself from the back, called a DRE test, a digital rectal exam, he found it was very hard. But he was confused. It's a very difficult kind of diagnosis to make because you have something that indicates something is wrong from the digital standpoint, and the PSA that indicate there was nothing really wrong. So what happened was it took this doctor 12 years to figure out what to do. It never did a biopsy. So in the 12 years that happened, it was a wait and see, do nothing kind of process. Unfortunately, the cancer grew, and the cancer grew beyond the capsule, and there I was in trouble.
Is the PSA still the most valuable tool we have, or is it starting to become secondary to other assessment tools that you have?
Well, good question. You know, the PSA test has been a source of a lot of controversy. It's been in the news quite a bit lately. It's a blood test, so it's a simple test to get. But correctly, it is non-specific for prostate diseases because it can be out of the normal range for conditions other than prostate cancer, prostatitis, prostate enlargement like BPH. So yes, it is somewhat confounding to use this test, but it is our best test, though imperfect. And at least as a blood test that's simple to complement the digital rectal examination, these are the best tests we have, and we need to know how to use the PSA test, including seeing how it changes over time, the so-called PSA velocity. So we still need to refine better tests in the future, but for the present, it still is a very good test.
So are there patients for whom doing nothing is a very reasonable decision.
Absolutely. And therein is one of the challenges that we face as surgeons dealing with prostate cancer. There is a lot of prostate cancer out there that may constitute a low threat situation. And conceivably, in those situations, we may want to counsel patients to think about being closely monitored, because the risks of the interventions, including impact on sexual function and urinary control, might exceed what the real risk of the cancer might ever be. So we are really challenged to try to figure out who we need to be very proactive with management and who we might counsel to follow.
If you've made the decision to have surgery, how much of the risk, in terms of some of these things that can happen that can really affect your life negatively going forward, how much of the risk flows from the skill of the surgeon that you're fortunate enough to have?
Well, I think that's a very important point. Prostate cancer surgery, I like to say, is almost like a sport. And you have to be really dedicated to it. You have to practice it. You have to become the expert at it. You want to be an all-star if you are going to dedicate yourself as a prostate cancer surgeon. And I think we owe it to our patients to be the most proficient surgeons we can be. There are some surgeons who don't perform this surgery very regularly, may not be quite as skilled. I think those surgeons perhaps should not be doing this surgery, and perhaps they need to understand that. And as patients, and the audience should hear here, that they may want to seek out very experienced, high-volume surgeons if you're going to go forward with a prostate cancer surgery.
Talk about the stories that were pulled together for the book. Are they as varied as the people telling the stories, or are there common themes that struck you?
Well, that's very interesting, because Dr. Burnett and I selectively, I mean, he actually decided that we're not just going to do random samplings of people who have prostate cancer. What we did was pick each patient had an issue or several issues, because if you put it all together, you get an idea of how complex this disease is, so that anybody who reads this book is in effect attending a portable support group. They hear these people talk, they get an idea of what they did right and what they did wrong, so that by the time you get through with this book, you have a whole range of people who did this kind of therapy, that kind of therapy, didn't do any therapy, what happened to them, what didn't happen to them. So by the time you get through with it, hopefully you'll be able to decide what I should do. Now, the trouble with most medical textbooks is that they present the disease in a very nice, compact way, and you learn a lot about how the disease, everything about the prostate and how it functions and what you should do. The problem with it is, what do I do as a patient? There's a lot of stuff that's in there that's conflicting and that's very complex, but the patient is left 3/4 of the time figuring out, well, yeah, this is fine. What do I do? All these people are suffering different things. And the reason we wrote this book is because we wanted to give the patient a companion that went along with a good medical text and said, okay, here's the story. Read your medical text, do the research. This is how we think you ought to figure it out.
I only have 45 seconds left. What's your advice for screening? At what age do you begin? How often? And how big a role does family history play in that calculation?
Well, very important. We know that men at age 50 should at least have a consultation with their physician about the potential risk of having prostate cancer. If you're in a high-risk group, men of African-American descent or strong family history, that discussion may occur at age 40. And basically the tests are the PSA and the rectal exam, at least to evaluate a man for the disease.
Arthur Burnett, MD, Director of the Male Consultation Clinic at Johns Hopkins Medical Institutions, journalist Norman Morris, a prostate cancer survivor. Thank you very much for being here. We recommend the book, Prostate Cancer Survivors Speak Their Mind.